Hi everyone, my name is Liz York and I would like to welcome you to today's CDC Partner Update Call on COVID-19. This call serves as a way for CDC to share weekly updates on COVID-19 and our latest resources and guidance. Today's call will focus on CDC's guidance for healthy buildings. First, we're going to hear from our COVID response acting chief medical officer, who's going to describe where we are with the response and give us insight into recent scientific findings. Then we're going to hear from two scientists who were pivotal in developing guidance focused on buildings and health. Afterwards, our speakers will answer questions we received over the last week via email. If you experience technical difficulties or otherwise would like to review today's call, you can find the recording on cdc.gov and YouTube in 8 to 10 days. All past partner calls can be found there, so please take time to review and share prior recordings. If this is your first webinar with us, these calls occur every Monday at 3 o'clock Eastern. Please see the link on the slide to subscribe and receive future call invitations. Please note, this call is intended for CDC partners involved in the response, and it's not intended for media. Should media who are listening have questions, we invite you to reach out to media@cdc.gov. Also, we will have two short polls, one now and another at the end of the presentations, to get feedback about the effectiveness of these calls. Please answer the poll on your screen right now as we get started, and then again before we start the Q&A session. Okay, so these calls are designed to share the latest science guidance and resources from CDC's website. There are over 2,000 documents providing information and guidance for individuals, businesses, and the public on cdc.gov. It can be a little overwhelming, frankly. In addition to the resources we'll discuss today, please check out these recent web editions. For the election season, CDC just released updated guidance for safer voting. Please see the link in the chat box. Another resource is the Emerging Infectious Diseases Journal. And since we're talking about facilities today, I wanted to link to an issue from earlier this year, COVID-19 outbreak associated with air conditioning in restaurant, Guangzhou, China, 2020. This issue describes an investigation that linked together 10 cases from 3 restaurant tables served by the same HVAC system. I'd also like to mention CDC's COVID-19 Science Update page. This page shares peer-reviewed research findings for various COVID-19 topics. The October 13th issue contains 2 studies about the length of time the virus survives on surfaces including glass, stainless steel, vinyl, and even human skin. These articles can be found in the laboratory science section with the link posted on the screen. Please check out the science update when you have a few minutes. There's always something interesting to learn there. So now I'm pleased to be joined by 3 CDC experts on the COVID-19 response. Dr. Cliff McDonald is Acting Chief Medical Officer for the CDC COVID-19 emergency response. Captain Dwayne Hammond is a mechanical engineer for the National Institute of Occupational Safety and Health in the Division of Field Studies and Engineering. And finally, Dr. Joel E. Kimmons is a senior scientist in the Chronic Disease, Nutrition, and Obesity branch of the Division of Nutrition, Physical Activity, and Obesity. I'm going to turn it over to Dr. McDonald for some updates.
Thank you, Liz, and welcome to everyone joining us today. Excuse me, thank you, Liz, and welcome to everyone joining us today. My name is Dr. Cliff McDonald, and as mentioned, I am the Acting Chief Medical Officer for the response. Today, I'd like to provide a brief update on the response and review some of the latest scientific developments. First, a situational update on cases and deaths. You can see from the slide that cases and deaths are increasing. One important statistic here is that the weekly average number of cases over the past 7 days is 18% greater than the previous week's average. This is a significant weekly increase in case counts and has been sustained after compounding over the past few weeks. Since October 5th, when cases were nearly 43,000 per day. Cases have increased 83% to almost 79,000 per day. What does all this mean? Well, when this percentage is decreasing, this tells us that mitigation efforts are working. When case counts increase, this tells us that we need to step up mitigation efforts to slow the spread of COVID-19. One additional note, 88% of jurisdictions, which includes states, territories, and some cities, are in an increasing trajectory for cases. This may be the greatest number of increasing jurisdictions for the entire history of the COVID-19 response. We encourage you to visit CDC's data tracker for the latest stats and COVID View for a weekly summary of key indicators for the pandemic. Now this week, I want to share some of what we've learned recently from 3 reports published in the COVID-19 Science Update. In the interest of time, I will only briefly touch on the high points of these reports, and I encourage you to visit cdc.gov to read the full report. The October 6th Science Update in brief, one of the in briefs listed there outlines a study showing that leaving elevator doors in the open position as much as possible and increasing the mechanical ventilation rate are strategies for reducing aerosol transmission of the virus in hospital elevators. Holding elevator doors open when idle reduces aerosol particles in the cab 6 times faster than when elevator doors are closed. A remarkable finding was that the ventilation inside all studied elevators automatically shuts off after 1 to 2 minutes, which of course can easily be prolonged by adjusting the elevator ventilation controls. See the link in the box for more information. The October 2nd Science Update, entitled Epidemiology, or under the heading Epidemiology, references a study describing how vascular chronic disease factors, including hypertension, diabetes, smoking, drinking, physical inactivity, and overweight status, were associated with increased risk of severe COVID-19 illness. People with these conditions may benefit from changes to their condition through exercise, smoking cessation, medication adherence, weight loss, and reducing alcohol use. Check the link for more details there. And finally, the September 25th Science Update under the section heading Diabetes-Related COVID-19 Mortality describes 2 separate peer-reviewed studies that describe COVID-19 related mortality rates in England. They reveal that diabetes has been associated with increased risk for COVID-19 related death. In addition, rates of non-COVID-19 death or related death for diabetes have also increased, possibly due to avoidance of care or other demographic and social factors in diabetic patients. In both cases, supporting people with diabetes in effective self-management during the pandemic is an important measure for mitigating the effects of COVID-19 infection. To read more about these and other reports, please follow the links on the screen. Before we move to today's speakers, I'd like to remind everyone that the flu season is here. With rare exceptions, the CDC recommends annual flu vaccination for everyone 6 months of age or older. I encourage everyone on the call to get your flu shot and to support flu vaccination efforts within your organizations. Now is a great time to get the flu vaccine. With that, it is now my pleasure to hand you over to my colleagues, Captain Dwayne Hammond and Dr. Joel Kimmons.
Thank you, Dr. McDonald. My name is Dwayne Hammond, and I'm a mechanical engineer with CDC's National Institute for Occupational Safety and Health. And I'm also part of the worker safety and health team within the CDC COVID-19 response. The title of my presentation today is Healthy Building Design for Pandemics and Beyond. So my talk today mainly draws from the content in CDC's interim guidance for businesses and employers responding to COVID-19, also referred to often as the general business guidance. Specifically, I'll focus on the engineering control section of the hierarchy of controls. This includes barriers, ventilation, filtration, ultraviolet germicidal irradiation or UVGI, and portable air cleaners. I will also talk a little bit about dilution ventilation principles and methods for capturing the virus at its source. One important point, this talk today focuses narrowly on engineering controls section of our guidance. Engineering controls should be used in combination with other prevention measures to slow the spread of the virus. Please notice the graphic at the right of the slide that it demonstrates a combination of layered strategies, including social distancing, masks, hand washing, cleaning, and disinfection, all of which are key mitigation methods for slowing the spread of COVID-19 that we will not cover in today's talk. So just as I mentioned in the previous slide, the CDC guidance includes substantial additional information on ways to slow the spread of the virus beyond the content of this presentation. This disclaimer basically says that the presentation isn't exhaustive, but it's meant to be helpful. I encourage you to read the full guidance by following the link in the chat box. There are also several links near the end of my presentation where more CDC related COVID-19 information can be found. So one of the first things you do when reoccupying the buildings are, the first step is to confirm that the building is operational and able to be occupied. You need to be sure that HVAC and other systems are operating properly. For HVAC systems that have been shut down or on setback, CDC recommends reviewing the and implementing standard startup guidance such as ASHRAE's standard 180-2018, which has been added to the chat box. And then the air in buildings can become musty or stale when shut down or set back. Flushing the building with fresh outdoor air is another good first step. Check all mechanical and life safety systems to confirm they're working properly and look for hazards. Hazards associated with prolonged facility shutdown include mold growth, rodents, pests. Also look for issues with stagnant water systems and remediate hazards that you find before beginning to reoccupy your building. Check out these and other strategies at the link in the chat box. According to the Occupational Safety and Health Administration, or Occupational Safety and Health Act of 1970, employers are required to furnish a place of employment free of recognized hazards that are causing or likely to cause death or serious physical harm to employees. This is accomplished through a hazard assessment. The general business guidance links to the OSHA guidance on hazard identification and assessment. According to OSHA, one of the root causes of workplace injuries, illnesses, and incidents is the failure to identify or recognize hazards that are present or that could have been anticipated. The COVID-19 hazard assessment for buildings would include identifying work and common areas where employees could be within 6 feet of others. That's just one example. Once hazards are identified, develop mitigation strategies and communication plans that include all employees, contractors, and others in the workplace. Ensure information is written in plain language, culturally responsive, and available in languages that represent your workforce. Discuss and finalize any changes that need to be made in the way people work in order to prevent transmission. So the hierarchy of controls, this slide shows the hierarchy of controls, and it's described several times in CDC's guidance. It's a fundamental concept for protecting workers. The most effective controls are at the top. Least effective controls are typically near the bottom, although there are opportunities for failure at any level of the hierarchy. For example, steps to eliminate or prevent entry of a pathogen into the workplace would be the most effective, followed by techniques to isolate workers from the virus using engineering and architectural controls. In the case of COVID-19, we need to separate workers from the pathogen and also from each other due to the asymptomatic transmission of the virus. Every single person in the workplace is a potential source of the virus. CDC recommends using a layered approach that implements controls from all levels of the hierarchy to protect workers in your building from a virus that spreads as easily as COVID-19. Here are some common examples of engineering architectural spatial controls that can be used to isolate workers from the hazard. A common approach is to modify or adjust seats, furniture, workstations to maintain social distancing of at least 6 feet between employees. I'm sure you've all seen plastic barriers being installed between workers and customers or walls between coworkers. Signs, draped fabric, and caution tape can help communicate when seats are off limits. Removing chairs and tables altogether is effective also. And be thorough. You can't do this well in some places and not in other places. All areas must be studied to be effective. This slide shows an airflow simulation that looks at the design of partitions by researchers from the Riken Center for Computational Sciences and Toyohashi University of Technology. The researchers set a condition that released approximately 50,000 particles, 1 micrometer and larger in diameter, while varying partition height between 4 office workers. The link in the below the image shows a video and results highlighting the importance of designing barriers tall enough to prevent droplet transmission. And results of the simulation showed many smaller droplets passed over 120 centimeter high partition that's about 47 inches. These droplets were blocked when the simulation was repeated for 140 centimeter high partition, which is about 55 inches. The article goes on to say, to prevent the virus from spreading effectively, partitions need to be as high as people's heads. Just to continue, there are still a lack of definitive minimum design specifications for barriers. Research is currently being conducted to identify the most protective dimensions and materials. Let's think about layering approaches. Again, barriers are designed to protect from larger droplets, while air pressurization and directional airflow can improve protection from smaller particles. Barriers can even help designers implement desired directional airflow. However, barriers can also potentially inhibit good airflow and mixing if not designed and installed properly. What is directional airflow, you might ask? The goal of directional airflow is to use pressure differential and airflow direction to remove potential contaminants, keeping them out of the breathing zone of occupants. By supplying slightly less fresh air than your exhaust fan pulls out of the space, a vacuum is created and contaminants can be removed that way. Design opportunities may exist to use barriers and pressure differences to create directional airflow in areas, in quite a few areas, such as reception stations, ticket booths, medical dental offices, and pharmacies. CDC's guidance also recommends improving ventilation in buildings. One strategy is to increase the percentage of fresh outdoor air that's being brought into the building and reduce the percentage of recirculated air. Another strategy is to increase total airflow supply to occupied spaces to help dilute contaminants, including the virus. Finally, you could suspend demand-controlled ventilation controls that reduce air supply when no one is there. Note that any of these steps should be done in consultation with an experienced HVAC professional. Simple things like opening a window can increase dilution of the virus in indoor air, or you can filter out the virus by using a more efficient air filter in your system, such as a MERV 13 filter. Check the filter fit and ensure there are no leaks in your HVAC system that will allow contaminants to go around the filter. Also, you can run the system a couple hours before people arrive and after people leave to dilute the air. Here's some data from a recent article published in the ASHRAE journal. It was titled Study of Viral Filtration Performance of Residential HVAC Filters. And I think the link was just provided in the chat box. You can see how the yellow highlighted column in the first table shows how the mean viral filtration efficiency increases as the MERV filter rating increases. You see 78% mean filtration efficiency of viral particles is what we found for MERV 12 filters, 89% efficient for MERV 13 and 97 for MERV 14. And that might be a little higher than what you've seen for some other like 1 to 3 micron range. I think is usually 85% for MERV 13 and 90% for MERV 14, but could be slightly different particle size there. The study is a good example of why MERV 13 filters are recommended in the CDC guidance. However, also notice that the increase in pressure drop shown in the yellow highlighted column in the second table. Too much pressure drop can mean that your system becomes overwhelmed and cannot effectively move the air through the spaces. Good reasons to consult with an HVAC professional to verify system compatibility before making improvements to ventilation systems. So as far as enhanced air patterns, engineering control information in the CDC guidance also includes recommendations to generate clean to less clean air movements by reevaluating the positions of supply and exhaust diffusers and dampers. The idea is to have staff work in areas served by clean ventilation zones and to exhaust less clean air rather than recirculating it back into breathing zone spaces. Also check restroom exhaust fans to be sure they are operating at full capacity. Adjust box fans and ceiling fans so that less clean air is directed out of the room or breathing zone. And people often ask about HEPA filters. They are very efficient at filtering infectious aerosols. but you need to be sure to select a quality HEPA unit and to match it to the size of the space. HEPA filters are more than 99.97% efficient at capturing human-generated airborne viral particles. When selecting a unit, you'll need to know how many cubic feet of air are enclosed in the area to be cleaned. Many portable HEPA units list what's called a clean air delivery rate, which is reported in cubic feet per minute, and may also list a recommended room size. The larger the CADR, the faster it will clean the air in the room. The CDC guidance also describes considerations for ultraviolet germicidal irradiation to help inactivate the virus in air. The slide shows two different configurations of UVGI, an upper room unit that inactivates the virus above the heads of occupants, and an induct system that inactivates the virus before air is delivered to occupied spaces. So source capture, containment, and removal. This is an example of a NIOSH ventilated headboard for a healthcare application. So the NIOSH ventilated headboard is a low cost, inexpensive, easy to set up, universal design for source capture, and provides a solution for patient isolation during an epidemic. This ventilated headboard pulls any patient-generated aerosols away from the workers and room and towards the HEPA filter, which removes it from the air. Laboratory tests show the NIOSH ventilated headboard captures and removes over 99% of airborne infectious size aerosols. More information can be found at the link at the bottom of the slide or in the chat box. In conclusion, architectural and engineering controls are important tools in preventing the spread of the virus in buildings, especially when used in combination with other prevention measures such as distancing, hand washing, masks, cleaning and disinfecting surfaces. Please review all these topics in depth on cdc.gov. Links will be posted in the chat. With that, I'd like to thank you for your attention and turn it over to my colleague, Dr. Joel Kimmons, who will be providing additional information related to healthy building design with particular attention to prevention of chronic diseases. Thank you.
Thank you, Liz, Cliff, and Dwayne. My name is Joel Kimmons. I'm a senior scientist with CDC's Division of Nutrition, Physical Activity, and Obesity within the National Center for Chronic Disease Prevention and Health Promotion. This presentation will extend Dwayne's comments to address the general importance of healthy building design to support wellness and chronic disease prevention. I'm going to talk about chronic disease risk factors and highlight building features, amenities, and policies that help keep building occupants healthier and prevent chronic disease. Dwayne has detailed a variety of actions that can be taken to reduce COVID-19 infection at the building level. These should be used in conjunction with other actions, including wearing a mask, social distancing, hand hygiene, cleaning, and disinfecting. Now, I've heard a little about this slide from the highlights from Dr. McDonald in the science update. Overall, it's important for design and facilities professionals to be aware that people with underlying medical conditions, such as those on this slide, are at increased risk for severe illness from COVID-19. My friend, such as Liz York here, will tell you, she's an architect, that designers and facility professionals have both the influence and power to mitigate these risks with design and policies. Chronic diseases such as these have multiple causes, many of which are influenced by exposure to the built environment and the resultant behaviors and choices. Therefore, the design and management of environments where we live, work, learn, and play can be an important part of wellness and chronic disease prevention. Americans spend over 90% of our time in buildings, and thus the opportunity for buildings to influence our health in a positive or negative way is formidable. Building features, amenities, and policies can influence our health in numerous ways. For example, easy to access stairwells can increase physical activity. Building features such as daylighting, sound control, and appropriate ventilation can benefit cognitive function, sleep patterns, and stress levels. Health and wellness promoting building amenities include gyms, exercise rooms, meditative gardens, and lactation rooms. Building policies and operational protocols can ensure easy access to healthy and safe foods. Building policies are also an excellent way to assure smoke and tobacco-free spaces for all. Cleaning protocols and integrated pest control policies can ensure that fewer harmful chemicals are used to maintain buildings. Taken together, building features, amenities, and policies can assist building occupants in living healthier lives. I will now highlight several specific strategies, as well as the Fitwel certification program that consolidates many of the strategies into one program. This slide highlights the food service guidelines for federal facilities, which are voluntary best business practices to increase healthy and safe options in institutional settings, such as work sites. Healthy eating patterns are associated with better immune function, which is important for us all, especially during times of a pandemic. The food service guidelines assist food operators in providing healthier foods and beverages that align with the dietary guidelines for Americans, enabling environmentally responsible practices, incentivizing food safety practices, and using behavioral design approaches, which are cognitive, emotional, behavioral, and informational strategies that enable or incentivize people toward healthier choices. Behavioral design approaches specific for operationalizing food service guidelines include creating and inviting light-filled dining and kitchen areas, placing salad bars in prominent locations, and putting only healthy options by the checkout, placing healthier foods at eye level, adding more kitchen storage for fresh and refrigerated foods, and adding fewer deep fried fryers. A worksite wellness program that includes physical activity, a physical activity component can help maintain healthier workforce, increase employees' productivity, reduce absenteeism, and increase morale. Worksites can encourage physical activity through a multi-component approach of offering management support, physical access to opportunities, policies, and social support programs. Physical activity enabling amenities include standing desks, indirect task lighting, and ergonomic chairs, gyms, and multi-purpose rooms for exercise, yoga, or team building activities, outdoor work environments and meditative gardens, and covered bicycle storage, showers, lockers, and access to cycling paths. Regardless of size, resources, setting, and type, all work sites can provide opportunities to promote physical activity for their employees. The CDC Health Scorecard is designed to help employers assess if they have implemented evidence-based health promoting strategies to improve the health and well-being of their employees. This instrument reflects the workplace health model approach, which includes a four-step process: assessment, planning, implementation, and evaluation, and has recently been updated to reflect the most up-to-date evidence on impactful strategies for improving employee health and well-being. The scorecard encourages owners to provide a working environment that features healthy building design principles, including access to natural light, exposure to plants and nature, communal spaces, good ventilation and air quality, comfortable temperatures, and no excessive noise. Please note that the examples I've mentioned represent only a small number of the building features, amenities, and policies that contribute to making a building a healthier place to work or play. CDC has worked to operationalize these concepts in numerous collaborations, publications, and the aforementioned tools. These strategies have also been consolidated into Fitwel, a healthy building rating and certification program. The Fitwel scorecard examines 7 wellness categories, as can be seen on this slide. They are used to rate a building's healthy features, amenities, and policies. Some examples include impacts community health and social equity by connecting your facilities to transit systems, instills feelings of well-being by providing views of nature, and promoting occupant safety by including AED devices in your buildings. Fitwel is created by the CDC and the General Services Administration and is operated by the Center for Active Design. Fast Company magazine named Fitwel one of the top 10 most innovative companies for social good. Fitwel optimizes building design and operations to improve health and productivity outcomes. More information can be found on the websites shown here. In conclusion, building engineering, design, and management play a key role in preventing the transmission of COVID-19. However, building design does more than just decrease the risk of individuals getting sick from infectious diseases. Healthy building design also plays a key role in the prevention and treatment of chronic diseases, including obesity and diabetes. By providing environments where people have the opportunity to make healthy choices, we can help individuals live healthier, higher quality lives. Thank you.
Thank you to Dr. McDonald, Captain Hammond, and Dr. Kimmons for sharing those updates. Next, we're going to have Q&A, but before we get started answering your questions, please take a moment and answer a couple of ours by taking the poll on your screen. This past week, we received many great questions in advance, and we will get to as many of those as we can in this next half hour. I'm sorry we won't be able to take questions from the chat box today, but we will likely not even finish all the questions we've already prepared. So bear with us, and we will get started on the Q&A in just a second. So let's start off with a question about testing for Dr. McDonald. Are any of the COVID-19 self-testing kits reliable? If yes, are they readily available? And what are the pros and cons of using such test kits?
Well, let me be very clear that what we are talking about here are viral tests, first of all, and that's in contrast to antibody tests. And second of all, that this, the current science or current status involves the home self-collection of a nasal or saliva sample that is then mailed or delivered by courier to the laboratory for testing. So these may be, in the case of nasal specimens, either nucleic acid amplification tests or antigen tests that are different from one another in terms of sensitivity, with the former more sensitive than the latter. Unfortunately, we do not yet have any tests that can actually be performed at home, similar to, say, a home pregnancy test. But those are tests we are looking forward to in some point in the future. We do now have what are known also as point-of-care viral tests. Those are mostly antigen tests that do not require performance in a laboratory, but they're not currently offered for use for a home testing. Thus, the question really translates to whether the at-home self-collection of nasal or saliva samples can be as good as that performed by healthcare providers in a testing center. The answer to that question is yes. At-home self-collection of nasal or saliva samples can be and commonly are performed as well as healthcare collected specimens. There is a slightly more sensitive specimen known as a nasopharyngeal specimen, only collected by healthcare providers that, although uncomfortable, may be slightly more sensitive than the specimen types collected at home.
Thank you, Dr. McDonald. Next, we have a couple of questions focused on architectural design issues. Captain Hammond, is there any evidence about infectiousness rates from various surfaces? Are there any skins or metals with antimicrobial properties that are effective in reducing transmission, especially on high-touch areas? And how can architects and designers think about materials in terms of their health protection properties, as well as cleanability, durability, cost, and beauty? Does the virus live longer on a metal bench that is easy to clean but terribly uncomfortable, or on a fabric-covered sofa, for example?
Thank you for the question. So current evidence, though still preliminary, suggests that the virus may remain viable for hours to days on surfaces made from a variety of materials. It may be possible that a person can touch, can get COVID-19 by touching a surface or object that has the virus on it, and then touching their own mouth, nose, or possibly their eyes, but this is not thought to be the main way the virus spreads. Architects and designers should consider materials that are easy to clean using products that meet EPA's criteria for use against the virus. Employers should develop a plan for routine cleaning and disinfection, including the regular cleaning and disinfection of high-touch surfaces.
Thank you, Captain Hammond. I have another one for you. I bet you've heard this one before. Do plastic screens between spaces actually protect people from getting COVID-19, or are they just making people feel better, but giving them a false sense of confidence?
As I described in the presentation, some research by the Riken Center for Computational Science and Toyohashi University of Technology in Japan modeled proper partition height needed to minimize the risk of spreading the virus from a cough using an example of an office environment. But in addition to the CFD models from Japan, there are also some laboratory and real world studies indicating barriers are effective and not providing a false sense of confidence. Barriers designed for protection from the virus that causes COVID-19 are most appropriate for droplet protection, but barriers can be enhanced with air pressurization, directional airflow to improve protection from exposure to smaller particles as well. Plastic screens or barriers are one type of engineering controls. Engineering controls are important to prevent the spread of the virus in buildings when used in combination with other prevention measures such as social distancing, hand washing, cloth masks, cleaning and disinfecting surfaces, among other recommendations mentioned in the CDC guidance.
Thank you again, Captain Hammond, for that. Guess what? It's your lucky day. I have another one for you. Our command has an auditorium space, which normally seats 280 people, but with social distancing only seats 50 people. There are no windows to the auditorium and the air is circulated via a typical building HVAC system. If we only have 50 people in the space, can they forego wearing masks given that they are maintaining 6-foot social distancing? And if more than 50 people are seated in the space, will wearing masks by participants be sufficient to prevent spread of the virus? So basically they're asking, is a closed room with only HVAC safe under any circumstances? Can you go without a mask?
You really shouldn't rely on HVAC alone to prevent the spread of the virus in buildings. In 2 weeks, on November 16th, during this same partner call, Dr. Lookout is going to talk about the importance of layering controls. And so layering is an approach that emphasizes using engineering and administrative controls in combination with each other to slow the spread of the virus. In other words, it's important to combine wearing masks with distancing, ventilation, and other engineering and administrative controls in your auditorium and other buildings to slow the spread.
That's great. Great information. Thank you. So what about buildings that house agriculture, meat, poultry, and other food processing industries that often involve working closer than the recommended 6-foot distance? Not only are workers at increased risk for getting and spreading COVID because of the conditions in these industries, but the industries are considered critical and less likely to close, leaving workers little choice but to come to work even when other businesses are shut because of high community transmission. Captain Hammond, can you talk a little bit about that?
So CDC has done a lot of work in this area and has detailed guidance for agricultural, meat and poultry, seafood, and other critical infrastructure workers. I see that's just been posted in the chat box, the links to those guidance documents. So those guidance documents, they were published jointly by CDC and OSHA and developed in consultation with the FDA. Each guidance document has specific information about how to reduce the spread of the virus, including at processing lines and other areas in busy plants where workers have close contact with each other and supervisors. So each document also contains links to toolkits and facility assessment checklists, such as the one provided for meat and poultry processing workers that will be added to the chat box. The checklists are intended to be used to help determine if facilities are utilizing the CDC OSHA guidance to implement practices and protocols for operating while safeguarding workers and the community.
Thank you. Thank you for that answer. So here's a question, and I think I'll start off trying to field the question, but then maybe get some help from Joel later on. In what ways do you foresee commercial building construction changing due to our experiences with the COVID-19 pandemic? Do you see these being requirements or recommendations? And will these be different for new buildings versus planned renovations versus facilities currently in use? So this is one of those crystal ball questions that CDC may not have an answer for, not an official answer. My personal take on it, though, is that the real estate industry has more information than it has ever before on infectious disease prevention strategies in buildings. Furthermore, there are studies going on that will continue to inform our design and construction strategies for years to come. And I would think that we will be designing with more attention to personal space, to ventilation, to outdoor working spaces, touchless operations, and cleanability as some examples of things we've learned as a sector. In terms of these being requirements or recommendations, I would look to how things have happened in the green building sector. Initially, organizations like LEED and the Living Building Challenge identified aspirational strategies for making buildings more environmentally responsible, and they established voluntary building certification systems. These systems allowed owners and designers to learn about and employ new sustainable technologies and strategies in their buildings, and over time, the knowledge in the sector increased around green building design. And then afterwards, requirements began to change to match the voluntary standards. So I would see it following a pattern similar to that. We've already seen it happening with healthy building certification systems. Well and Fitwell, that Dr. Kimmons mentioned, has already released a viral response module that CDC helped facilitate. This module addresses many of the strategies that can be employed in buildings voluntarily to make them healthier in terms of infectious disease prevention. If you want a peek into that crystal ball, I personally recommend taking a look at these kinds of certifications and seeing the strategies that they outline. So Dr. Kimmons, did you want to add anything?
Yeah, Liz, well, that's pretty well said and pretty well covered. I'll add just a little bit. Using behavioral design to create healthy spaces where people can thrive and be productive has advantages that go far beyond the prevention of infectious disease, as I mentioned earlier. Healthy buildings contribute to improvements in overall health and wellness, which increases resilience to both psychological and physical adversity. Thus, whether it's just the stress of work or the pandemic, whether you're trying to protect yourself from infectious disease like flu or COVID-19, healthy buildings provide a foundational support to our nation's health. And then I think the one thing we didn't really get to was whether this is new or planned renovations in these areas. And I think with Fitwell, it was really designed to be able to fit into both new buildings or various levels of renovation to be able to get to these ideal, optional, healthy amenities policies for buildings.
Thanks, Joel. I appreciate that. So Dwayne, guess what? We're back to you. Can you offer any immediate strategies for better air quality and minimizing opportunities for COVID-19 spread within occupied commercial buildings like schools, healthcare, and hospitality?
Yeah, so applying a combination of increased filter efficiency and increased ventilation rates may be the best way to achieve better indoor air quality and help dilute the virus that causes COVID-19. Other steps include things like using portable high-efficiency particulate air or HEPA fan filtration systems to help enhance air cleaning, especially in high-risk areas. You may also want to consider using ultraviolet germicidal radiation, UVGI, as a supplement to help inactivate the virus, especially if options for increasing room ventilation are limited. So these strategies, as well as others mentioned in the CDC guidance for office buildings that was linked earlier, and CDC's considerations for operating schools during COVID-19 provided in the chat box.
Captain Hammond, one other question in this area. Is there any research underway regarding how to mitigate COVID-19 transmission in buildings?
Yes, that's a great question. I've heard that CDC Foundation funded a project for the National Institute of Standards and Technology to conduct simulations aimed at evaluating the effectiveness of intervention strategies to reduce the spread of infectious aerosols in buildings. I understand that this research will culminate in a white paper providing technical information to support evidence-based guidance. The guidance will target recommendations on filter efficiencies, HVAC runtimes, use of portable air cleaners, occupant density, and increasing the amount of outdoor air. Although the primary focus of the research is on residential buildings, the project will include exploratory simulations for other important occupancies such as dormitories, older adult housing, cruise ships, and restaurants.
Thank you, Captain Hammond. Speaking of research studies, here's one for Dr. McDonald. I have a friend who was diagnosed with COVID-19 about 6 months ago. She has recovered, but since then, her sense of taste has not come back to normal. It has become so abnormal that it has virtually ruined any taste sensation for her. Are there any research studies which she could join that are focused on this issue?
Well, let me just begin by saying how sorry I am. that your friend is suffering in this way. The loss of taste is sometimes referred to in the medical literature as ageusia, and the loss of that's spelled ageusia, and the loss of smell as anosmia, anosmia. I'll just mention those terms because they could help you in your search for help for your friend. Of course, these senses of taste and smell are very interrelated, and both of these symptoms are frequent in early stages of symptomatic COVID-19, reported in some series over 75% of patients. While these symptoms can occur with other respiratory virus infections in areas where COVID-19 incidence is high, they can be pretty predictive symptoms for COVID-19. The persistence in loss of taste for 6 months or more is uncommon. For instance, in one study of 138 patients, persistence of the loss of taste or smell beyond 60 days only occurred in about 7% of patients. One place to look up studies, up-to-date status on ongoing research studies is what's known as clinicaltrials.gov, a website. You can see the link in the box. There you can search for open clinical trials. Unfortunately, in my quick look at that site for relevant studies, I did not find any studies in the United States, only one in Egypt, looking at early corticosteroid use for prevention.
Thank you, Dr. McDonald. Captain Hammond, I'm coming back to you. What role does disinfection play in mitigating COVID-19 transmission, and how often should surfaces be disinfected? Are there health implications of disinfecting too often?
Well, thank you for the question. And thinking about the role disinfection plays in mitigating COVID-19 transmission, it may be helpful to review the information on the CDC website about how COVID-19 spreads. And that link should be provided in the chat box. Infections occur mainly through exposure to respiratory droplets when a person is in close contact with someone who has the virus. It spreads less commonly through contact with contaminated surfaces. The best way to prevent illness is to avoid being exposed to the virus. You can take steps to slow the spread, just as Dr. Kimmons outlined in his presentation. Stay at least 6 feet away from others whenever possible. Cover your mouth and nose with a mask when around others. Wash your hands often with soap and water. Soap and water not available, use hand sanitizer that contains at least 60% alcohol. Avoid crowded indoor spaces and ensure indoor spaces are properly ventilated by bringing in outdoor air. In general, being outdoors and in spaces with good ventilation reduces the risk of exposure to infectious respiratory droplets. Stay home and isolate from others when sick. Routinely clean and disinfect frequently touched surfaces. And so in terms of disinfection, I'm guessing you mean the second part of that question, routine everyday cleaning of businesses and community facilities. So surfaces frequently touched by multiple people, such as door handles, bathroom surfaces, and handrails should be cleaned and disinfected with soap and water or detergent. These surfaces should be cleaned at least daily. When facilities are in use, more frequent cleaning and disinfection may be required based on level of use. And the last part of the question is about the health implications of disinfecting too often. Many factors influence whether a chemical used for disinfecting surfaces will cause health problems. Chemicals in some cleaning products can be irritating to the skin or can cause rashes. Cleaning products that contain corrosive chemicals can cause severe burns if splashed on the skin or in the eyes. Mists, vapors, and or gases from cleaning products can irritate the eyes, nose, throat, and lungs. Chemicals in some cleaning products can cause asthma or trigger asthma attacks. So mixing cleaning products that contain bleach and ammonia can cause severe lung damage or death. So cleaning staff should be trained on appropriate use of cleaning and disinfection chemicals and provided with and wear masks and the personal protective equipment required for all of the cleaning chemicals used.
Thank you, Captain Hammond. One more about HVAC. What role do HVAC systems play in transmission of COVID, and how can we leverage these systems to mitigate transmission? And then a specific question of how many air changes per hour should we be aiming for in our spaces?
So the risk of spreading the virus that causes COVID-19 through ventilation systems is not well known at this time, but it is likely low. Viral RNA has reportedly been found on return air grills, in return air ducts, and on heating, ventilation, and air conditioning filters themselves. But direct viral RNA alone does not imply capability of transmitting disease. There is no evidence to believe viral virus has transmitted through an HVAC system to result in disease transmission to people in other spaces served by the same system. HVAC systems can be a tool to help provide cleaner air in a facility, although it is never the first line of prevention. Consider general ventilation adjustments in your workplace, such as increasing filtration, improving ventilation, increasing the amount of outdoor air used by the system, maintain the indoor air temperature and humidity at comfortable levels for building occupants. Regarding a question about air changes per hour, cubic feet of air per person per hour, CDC does not have specific recommendations for ventilation rates for all facility types. Professional associations such as ASHRAE, the American Society of Heating, Refrigerating, and Air Conditioning Engineers, publishes minimum ventilation rates. For example, ASHRAE states that the minimum ventilation rates during occupied periods should be at least, or should at least meet the recommendations of ASHRAE 62.1. Healthcare facilities have ventilation requirements in place to help prevent and control infectious disease that are associated with healthcare environments. For example, airborne infection isolation rooms call for greater than 12 air changes per hour for new construction as of 2001, and greater than or equal to 6 air changes per hour for construction before 2001. Ventilation specifications for isolation anterooms are greater than or equal to 10 air changes per hour. And 15 air changes per hour for operating rooms. Ventilation rates vary among the different patient care areas of a healthcare facility. For more information, see CDC's guidelines for environmental infection control in healthcare facilities, provided in the chat box. Non-healthcare, e.g., for example, businesses and schools, building owners and managers should maintain ventilation systems according to state, local building codes and applicable guidelines.
So, Captain Hammond, how about fans? How do fans figure in? Do they work and are they safe?
Regarding fans, if fans such as pedestal fans or hard-mounted fans are used in a facility, take steps to minimize air from fans blowing from one worker directly at another worker. If resources allow, ceiling fans with upward air rotation combined with upper air UVGI disinfection systems can be utilized to slow the spread.
Okay, and here's another, does this work? Do air purifiers really work, and do they actually clean the air?
It depends on the type of air purifier. Portable high-efficiency particulate air, HEPA fan filter systems, as mentioned in the presentation, can help provide enhanced air cleaning, especially in high-risk areas. Research has shown that the particle size of the virus that causes COVID-19, it's around 0.1 micrometers in diameter. However, naturally generated viral particles generally do not travel through the air by themselves. Instead, they are trapped in respiratory droplets and droplet nuclei, which is dried respiratory droplets that are predominantly 1 micrometer in size and larger. By definition, a HEPA filter is at least 99.97% efficient at capturing particles 0.3 micron in size. So this 0.3 micron particle approximates what's called the most penetrating particle size through filter media. HEPA filters are even more efficient at capturing particles both larger and smaller than the most penetrating particle size. Thus, HEPA filters are more than 99.97% efficient at capturing naturally generated viral particles associated with the virus that causes COVID-19. And I probably have a lot more I could say about portable HEPA filtrations that they work. In the interest of time, maybe we can move on to the next question.
Sounds great. So the next question is for you also. What level of air filtration is effective in reducing the transmission of airborne infectious disease? And is bipolar ionization or ionization of any sort effective when it comes to mitigating airborne transmission? Finally, this question asker asked about MERV 19, MERV 13, HEPA, what is needed, and what are other concerns we should consider?
Certainly, and I'll take this question in reverse order. I won't cover HEPA since I just talked about it, but as mentioned, a recent article published in the ASHRAE Journal provides some quantitative information about the level of air filtration that's effective. That publication showed about 89% of MERV 13 effectiveness for filtration of viral particles and 97% for MERV 14. Regarding the question about bipolar ionization or ionization of any sort, it's important for me to emphasize that CDC does not provide recommendations for or against any manufacturer or manufacturer's product. While bipolar ionization has been around for decades, the technology has matured, and many of the early potential safety concerns are reportedly now resolved. So if you're considering the acquisition of bipolar ionization equipment, you will want to be sure that the equipment meets UL 2998 standard certification, environmental claim validation procedures for zero ozone emissions from air cleaners, which is intended to validate that no harmful levels of ozone are produced. And then lastly, the ventilation interventions considered are listed in the CDC guidance come with a range of initial costs and operating cost, which along with risk assessment parameters such as community incidence rates, face mask compliance expectations, and building density may affect considerations for which ventilation interventions are implemented. And acquisition cost estimates per room for the listed ventilation intervention range from $0 for opening a window, inspecting and maintaining local exhaust ventilation, disabling demand control ventilation controls, or repositioning outdoor air dampers, to less than $100 for acquisition costs using fans, increase effectiveness of open windows, or repositioning supply exhaust diffusers to create directional airflow, or approximately $500 adding portable HEPA fan filter systems to $1,500 for upper room UVGI.
Thank you. Thank you, Captain Hammond. I'm going to skip down and give Dr. Kimmons a question and give you a chance to breathe. Dr. Kimmons, let's talk about outdoor spaces a little bit. A concession group plans to operate an outdoor marketplace for retail gift buying in Washington, D.C. What guidelines and protocols should be taken into consideration and followed for COVID-19 and maybe also for chronic disease prevention?
Almost falling asleep out here. Yeah, glad to give Captain Hammond a break. Yes, good question. And the fact that the market is outdoors is really good. The fresh air, sunlight, breezes, all positive for chronic disease prevention, as well as combating viruses. If people are walking to the market, then as part of the person's physical activity, daily physical activity, it's good for chronic disease prevention. You can add bicycle racks nearby and encourage people to bike. Increases your radius of active transport, gets more people there with more exercise for more distance. Limiting the number of people and having people sanitize or wash hands before they walk into an area are good first steps. Potential sources of exposure can occur while working in a retail stand if you're in close contact with someone with COVID-19, or by touching your nose, eyes, or mouth, and handling items used by someone with COVID-19. So you need to break that transmission. Spreading this out can help, so to keep patrons more further apart, maintaining and sort of iterating repeatedly to maintain that social distance of at least 6 feet. Touchless payment methods, we're all getting familiar with, we're all getting good at. They can really minimize handling cash, credit cards, mobile devices. Routine cleaning just needs to be, seems like we've hit this over and over again today. With infectious disease, you always go back to the basics. Hand washing, hand washing, hand washing. So disinfection between touch surfaces. So as often as things can be sanitized, the better. There's some additional simple measures that can be implemented to physically separate and increase distance between people. Signage can be placed throughout the market to remind employees and customers to maintain distances. Move to electronic payment methods. Again, got to get away from cash here. Place visual cues such as floor decals or ground markers, color tape, signs, indicate where customers can stand to keep a distance. Place barriers like plastic sneeze guards. However, as Captain Hammond mentioned earlier, the guards need to be certain heights to be effective, or higher the better in a way. And then it's really important that you collaborate with state and local health officials to the extent as possible on how to implement each of these considerations while adjusting to meet the unique needs and circumstances of the local community. So you really got to talk to the businesses, talk to the local government, and see how ideally you can get you can organize this.
Well, we have some more questions, but we don't have any more time. So we're going to move to close our meeting out today. This concludes our time together. Dr. McDonald, Captain Hammond, and Dr. Kimmons, it's been a pleasure being here with you today. Thank you for everyone who has joined our call today. And I want to answer the most asked question. Yes, there will be a recording posted for this meeting online on CDC's COVID-19 webpage and on YouTube in a few days. The subscription link to receive future updates and invitations to this call is listed on the slide. And I want to say thank you again, and please join us next time, Monday, November 9th, when our topic will be vaccine distribution and safety overview. Until next time, be well.